In today's video, we're going over the clinical examination of meniscus tears. What's going on, guys? This is Dan Pope and Kevin Coughlin. We are physical therapists who work at Champion PT and Performance. We're here going through the medical literature, taking out all the pearls and sharing with them, sharing you. We're doing things. We're sharing. We're going through clinical pearls. I'm going to redo this one, Kevin.
That's all right. That was pretty good. Go ahead.
We're here going through the medical literature, taking out the clinical pearls and sharing them with you. How's it going, Kevin?
It's going well. This is one I'm very excited about. I think our previous episode was a lot of background information, so just learning more about the meniscus. But I think this is what we love to do, kind of be physical therapists and talk about how we evaluate this thing and how we examine it and figure out if they have a meniscus tear or not. So I think this will be a good application episode.
I agree. Let's get it going.
All right. So just to review a little bit, when you have your patient coming in with a potential meniscus tear, what are you going to hear on the subjective examination? So there's definitely things you want to be looking out for. Obviously, in our sporting population, we see a ton of different types of knee pain, and we have to be able to differentially diagnose. So some key things that you're going to be listening for a meniscus tear, especially in our younger folks, generally there's a mechanism of injury. So you want to pay attention to that. Did this occur gradually over time, or was this a sudden thing? So we'll talk a little bit about each of those. But for the acute injuries, they're going to come in and explain a mechanism of injury. Often there is a twisting component, so like a pivot twist type thing. That's usually associated with sharp pain in the knee joint. And they sometimes can feel a snap or a pop, but definitely not always. I think an interesting thing about the meniscus when you're asking about swelling is oftentimes there's a little bit of a delay. And I'm sure this depends on severity and location and a couple other factors. But there's a delay where sometimes they don't have swelling till the next day. Anecdotally, I had a meniscus tear when I was in high school. Cross country, man, it will get you. I was running up a hill and it was a pivot twist mechanism. So like I was turning left and I had my right leg planted and I must have kind of kept it planted as I rotated over it. And I had some acute medial knee pain, kind of fell to the ground. I think I just lost my balance, but I got up and I was able to finish the race. I think there was a lot of adrenaline. I went home. I don't remember anything terrible. My knee might have been a little sore, but waking up the next morning, my knee was like ballooned up and I could barely get out of bed. It was pretty wild. So, I tend to remember that with the meniscus, that there can be this delay and it could be even the next day. Sometimes it's even a little bit further down the road. So something interesting to keep in mind versus your ligamentous injuries, you tend to see swelling a little bit more quickly. Mm-hmm. But again, keep in mind, this can happen with this type of mechanism can lead to multiple injuries in the knee. We could have a meniscal injury. We could also have a ligament injury like your ACL. So, that's not a dead giveaway, but something to ask the patient about. When did you first notice the swelling? What activities did they have pain with? They're going to explain pain with, depending on the severity, maybe even just walking, but perhaps stairs, squatting, different things that are loading their knee joint. If they have a flap or a bucket handle tear, they might explain that they have some mechanical catching or locking of their knee. So that's something you're going to want to ask about. But if they don't have this, it doesn't rule out a meniscus tear, but something you want to try to figure out. So those are a few things to listen to on the subjective exam.
Hey, yo, I've got something for you. It is an evidence-based cheat sheet on meniscus pathology. And I get it. Stay on top of literature for all the pathologies are coming out. Very tough as a physical therapist. Well, I'm going to try to simplify it for you. I've taken all the relevant information about the meniscus and jammed it all together into a cheat sheet. And my promise to you is I'm going to catch you up to date on meniscus pathology in under 10 minutes. In the cheat sheet, we go over mechanisms of injury, prevalence, acute injuries versus chronic injuries, anatomy of the meniscus, examination, types of meniscus tears, surgery versus physical therapy, and some rehabilitation principles for you. So I'll leave a link in the show notes in the description below. This is 100% free. Go ahead and click on that link, download it, and get learning. Now back to your video. Yeah, one thing I will say, and I agree with you totally, Kat. I'm not trying to say you're wrong, but you will, over the course of your career, have a few patients that have like an ACL injury, meniscus tear with no swelling, which I also find to be interesting. I can think of two patients off the top of my head that they had an ACL tear with a meniscus tear, and they injured it. They heard a pop, but they never had any swelling whatsoever. And just because there's no swelling doesn't mean that there's not going to be an injury there. But yeah, oftentimes when people injure something in the tibiofemoral joint, whether that's meniscus or ligament, usually there's going to be some swelling.
All right. And then if we just get into our more chronic type person. So again, perhaps this is an older person coming in with knee pain. Their mechanism of injury, they might not know kind of when this started. They've had gradual knee pain for several months, perhaps years, or it could be a little bit more recent. So the knee pain is associated with intermittent swelling and or mechanical symptoms. I think Dan made a good point, right? Not every single time. We can't say that swelling has a 100% specificity for meniscus tears, but something to keep in mind. And intermittent swelling probably based on what they're doing, right? If they have a weekend where they're doing a lot of yard work or work in their garden, maybe after that they notice some swelling in the joint. They rest it, they kind of like take a day off and the swelling goes down. So this might not be swelling that's there all the time, but do they have intermittent swelling? I think for me, that's a flag that something's going on in the tibiofemoral joint. So, something's in there is aggravated. They tend to have pain depending on the location of the meniscus tear with deep knee bending or twisting. Sometimes if they have, we'll talk about more of an anterior meniscus tear, they might have pain at kind of terminal knee extension. So maybe when they're standing for a long period of time with their knee locked out, they feel better with their knee slightly bent. If they're playing sports that require rapid acceleration, deceleration, or change of direction and jumping, they might get a flare up of their symptoms while they're doing that. There was a study that looked at the average age of a 32-year-old and recreational or higher level athletes that were asymptomatic. And 27.2% of these athletes had meniscal damage. So again, these were asymptomatic athletes. And 3.9% had a meniscus tear. We also see higher rates of osteoarthritis we talked about, like, if you play sports throughout your whole life, it does increase stress in the knee joint, and you may be at higher risk of a chronic meniscus tear. So we see higher rates of meniscus tears and arthritis in ex-soccer athletes. And then just in the subjective, figuring out what this person does for work. If they have a more labor-intensive job, maybe a flag goes up, this could be kind of a chronic meniscus type thing. But something to keep in mind there, just in terms of what their daily activities look like and what stresses in their life are flaring their knee up a little bit.
Yeah, for sure. One of the things I think about sometimes with these chronic or degenerative tears, and you kind of mentioned, let's say an older patient that does a bunch of gardening one day. So they're doing a lot of kneeling, kind of lunging, stuff they typically don't do. Maybe it's good weather and they're just doing some gardening that day. Their knee ends up getting real swollen. It could certainly be meniscus pathology. The other one that kind of coexists sometimes with meniscus injuries, chronic ones anyway, degenerative ones, also some knee OA, right? So if you're seeing a patient that has more swelling of the joint, like Kevin said, you're thinking more tibiofemoral. For that older patient that didn't like cut while they're playing soccer, they're just doing something around the house. That starts, at least for me, to start thinking about maybe this is more of a degenerative tear, right?
All right. Now getting into testing for meniscus pathology. And we have some great images here from Dan Pope. These look like you. When did you film these or record these? Do you remember?
I want to say this was like just as COVID hit. This was like, I want to say beginning of 2020. Because I remember shortly after this student had a very tumultuous next few months.
Oh yeah, that's tough.
Yeah.
Yeah,
I
good
guess
old days.
Clay Cinnamon. You know Clay?
No, that was right before I started.
Okay, yeah. Believe that's him. So shout out to Clay. Great
Yep.
job.
Yeah, so I think all these images were still really relevant. So that's why they're in the slides here. But just to summarize that subjective information, so oftentimes associated with a twisting injury, they had oftentimes a tearing sensation at the time of the injury or a snap up in the knee. Oftentimes they do have that delayed effusion. It's not always immediate, like we do see with ligamentous injuries. There may be a little bit of delay. They may explain a history of catching or locking in the joint, and they might have pain with different activities at end range knee flexion and end range knee extension. So you hear those things. Now we're going to dive into the objective exam and kind of what we're looking at.
Yeah. And what I will say, and I'm sorry if I steal your thunder, Kevin, but if you have a patient that it sounds like they had an acute injury to their meniscus, then I'm already thinking we probably want to send them to the doctor before we start doing physical therapy. It's not like you can't do some physical therapy with them that day, but we probably do want to send them in for some imaging just to see what the heck is going on, right?
So we do have clinical practice guidelines for meniscal injuries. There was a revision of the previous clinical practice guideline in 2018. I don't think we have a new one since then. And I think if they were going to do one, they would do one right now. By now, I believe it's every 4 years. Is that right, Dan? Sound
I
right?
don't know. I have no idea, to be honest with you, but yeah, they might be a little bit behind if that's the case.
Yeah.
Yeah.
So this is our most recent one, but I think it's still very relevant. So there's B level evidence, which just means that there's at least one high level randomized controlled trial or other high quality studies showing that this is worth doing. And what we're going to be assessing for objectively is swelling. So we like to do this with like a sweep test where you apply a medial force and an upward force to the medial part of the knee. And then you come down laterally and try to sweep that swelling back. And we're trying to grade how much swelling is in the knee there. We want to be assessing active range of motion. So we could do this either with a standing kind of functional movement assessment, looking at different movements of the knee, or we assess this on the table and see how much they're willing to bend or straighten their knee. If it's appropriate, we want to test their strength. Now, if we are suspecting a meniscus tear, and generally what I'll do is I'll set them up in like a manual muscle test and see how much force they can produce and how comfortable they feel doing that. If they feel comfortable, it's not reproducing pain, they don't feel terrible, then we'll go ahead and do a test with our dynamometer. But if that position is very provocative and they don't feel great doing that, I'd still like to test their other side if we can. So we get some good baseline data on what their quad strength is and their hamstring strength is on the good side. In case they end up doing any type of surgery, we have good pre-op numbers. We definitely want to be looking at passive range of motion and getting numbers for that. We tend to see a loss of either knee extension and or knee flexion with these folks. And they will have pain. I think it depends on if someone has a lot of swelling in the knee, you tend to see pain with extremes of either end of the motion. So you do some hyperextension, you do some hyperflexion, they're going to get pain because there's really nowhere for that swelling to go. If there's not a lot of swelling in the knee, I think this might depend on where the meniscus tear is. So if someone has an anterior tear of their meniscus, you tend to see pain with forced hyperextension of the knee. So just be gentle going into that. I always like to test the uninvolved side first so they have a good baseline. They know what normal feels like. And then just be gentle because you don't want to make this person, scream on the table and they're in a ton of pain. Same thing with the knee flexion. Kind of ease into it, see how they tolerate it. Don't go crazy. Again, I think it depends on the swelling and the location of the tear, but we want to be looking at passive range of motion. And then, I think if all signs are pointing to positive, we don't have to kill these people with a special test, but they are useful to do. I mean, I think we'll talk about this towards the end, but there's a really good cluster of special tests for the meniscus that we want to consider, having access to so we can be more confident ruling in or ruling out. There's more special tests than these two, but McMurray's is a good one you can do. Palpation of the joint line is a good one you can do, but we'll get into that kind of in the next slides here.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. Now, before we get into this, I think one of the dead giveaways for meniscus pathology is just a location of someone's pain. So there's a lot of pain in the anterior knee for athletes, patellofemoral pain being the biggest one, patellar tendinopathy, Osgood-Schlatter, quad tendinopathy. And you certainly can have anterior knee pain with meniscus pathology, depending on where that meniscus tear is. But I think one of the other dead giveaways when people start pointing to other parts of the knee. So medial, lateral, posterior, you can have pain in all of these regions. And oftentimes it's around that joint line, right? And that's one of the differential diagnosis pieces for things like pes-anserine pain or IT band pain or other forms of medial or lateral knee pain that are not from the tibial-femoral joint. If they have pain right on that joint line, that's where their pain is, you're starting to think this is maybe more meniscus pathology. And the one thing, I don't think you're going to go over this, Kevin, but I may be wrong. Just keep in mind that the semimembranosus does attach to the medial meniscus on the posterior horn there. So if you're doing some strength testing for the hamstring and knee flexion, you might have a little bit of pain, potentially because you have an injury there as well. So just one of the things to keep in mind. It's not super common, but you may find, oh, this person has pain with knee flexion. I wonder why. Could actually be the meniscus there.
It's a great clinical pearl, Dan.
Oh, a lot of pearls, man.
I like that. Yeah. All right. So more amazing images here of Dan. So these are really good. So I think you took these from the clinical practice guidelines. So, they're awesome. So testing for meniscus pathology, we have a few special tests that we have at our disposal. McMurray is a very common one that you'll hear. For this, you want to, you could test medial or lateral meniscus. So to test the lateral meniscus, we internally rotate the tibia and then go from knee flexion to knee extension. We're looking for a reproduction of the patient's pain or an audible click. For the medial meniscus, we're externally rotating the tibia in knee flexion, and then we're extending the knee with maintaining that stress. And again, we're looking for pain or an audible click. Again, hopefully it's their pain, the type of pain they've been feeling. And then a little bit about the sensitivity and specificity. So for the medial meniscus, the sensitivity of this test is 50%. It's not the best. For the medial meniscus, the specificity is 77%. So a little bit better specificity. I think in combination with all the other things, you could feel somewhat confident in a positive test here. And then the sensitivity of the McMurray's for the lateral meniscus is 21%, so not great. And the specificity for the lateral meniscus is a lot better. That's 94%. So I think zooming out, what does that tell us? If you get a negative test with a McMurray's on either the lateral or medial meniscus, it doesn't do a great job of ruling it out. We're not so confident that they don't have a meniscus tear. If some of the other things that we talked about during the subjective are consistent with a meniscus injury, if they have some delayed swelling, they have pain at end range knee flexion extension, we're not sure. They tested negative with this. We're not going to say they don't have a meniscus pathology. But if all those other things, and we'll talk about the cluster in a little bit here, but if they do test positive with a McMurray's test, we get a little more confidence that perhaps they do have a meniscus pathology. So, a little better at ruling in, not great at ruling out.
Yeah. And what I will say too is that I'm going to do another video where I show a lot of these special tests and try to review some of the literature on this. And the meniscus is very similar to other parts of the body. I remember when I came out of PT school, there was a study that just came out on the Thessley's test, and it was like 98% sensitivity and like 100% specificity. And I was like, oh yeah, this is really, really good test. And then 1 year later, another study that came out that was like 20% sensitivity and specificity.
Yeah.
So I think you'll find this, that there's the sensitivities and specificities are all over the place. And certainly some tests are better than others, right? The other thing is when you cluster them together, we probably get some better results. But I will say, what you probably need to know as a physical therapist is that if you have a clinical suspicion this patient has a meniscus injury, we can send to the doctor, and then we have better tests through imaging to show if that person actually has meniscus pathology. And then we can come up with a really good plan of care. This patient needs surgery. Should we try conservative care? So on and so forth, right? So they just serve as a way to start to think, oh, this might be meniscus related. And if so, that'll guide your next steps.
The next test we can do is a joint line tenderness test. So as Dan had mentioned, to kind of figure out if this is meniscus versus a different type of knee issue, they're going to talk about pain on the joint line, right? You don't get that with patellofemoral pain or patellar tendon pain or some of the other common types of pain. That joint line tenderness is kind of not a dead giveaway, but something that will make us strongly consider that this is a meniscus pathology. I guess the other thing I'd say is sometimes folks can get a distal femoral condyle bone stress injury or an injury to their tibial plateau, and that sometimes appears to be in the joint. So just other things to consider, but the mechanism is going to be pointing to this meniscus injury. Then joint line tenderness is definitely something we want to pay attention to. In terms of positive, so I guess to do this, you want to bend the knee a little bit. You want to have a little bit of knee flexion so you can access that front of the knee joint, and then you're going to palpate medially, palpate laterally. I think just one thing I see with a lot of our students in the PT in our clinic is that with palpation, a lot of times they don't palpate kind of hard enough. They're kind of gentle with their palpation. And we definitely see this with tendons. I think a lot of times you have to really squeeze it and apply more pressure than you think. I think the same thing goes for meniscus pathology. Obviously start a little lighter and see if you can reproduce symptoms, but don't be afraid to really poke, because they shouldn't be getting knee pain with that. So sometimes to get a positive test here, you have to do it correctly. So don't be afraid to really poke the meniscus or poke the joint line and see if it's reproducing pain. In terms of, you gonna say something?
Oh yeah, finish your thought though.
Yeah, I was just gonna talk about the sensitivity and specificity. So Just in terms of the sensitivity, the medial meniscus is 83%. The lateral meniscus is 68%. So that's kind of fair. You know, if they don't have it, if they're testing negative, perhaps we don't think they have one, you know, that's something to consider. A pretty similar specificity. So the medial meniscus is 76%. Really good specificity for pain on the lateral joint line for the lateral meniscus, as high as 97%. So, you know, if you do get if you do get pain there with this special test, perhaps we do have a lateral meniscus tear. So keep those numbers in mind.
Yeah, for sure. I was going to say another clinical pearl. Just make sure you test both sides, poking on left, poking on right. And then if it is tender, you can always ask, is this the pain that you came here today for, right? Is this the pain that you've been experiencing recently, as opposed to, is it just tender? And what I will say is, like, I've been practicing for over 10 years now. Sometimes I'm still digging in there, having a hard time finding the joint line. And the students are probably like wondering, what the hell are you doing, Dan? It's like, I'm just having a hard time finding that joint line. And then once you get in there, like, okay, this is it. And you can follow it along. So yeah, really dig in there and make sure that you're actually finding it. And even after 10 years, sometimes you might have trouble. Maybe that's just me, but you know,
No,
does happen.
especially when someone has a lot of swelling. It's like, where the heck is the joint line? It's
Yeah.
just, yeah. No, but you're absolutely right about testing the other side. That you have to do that, because I can think of someone I had recently. It was painful to palpate their uninvolved joint line. Like, it doesn't feel phenomenal, but it's different than palpating a meniscus tear, perhaps. So, you know, just keep that in mind. Definitely test the other side, because you don't want to get thrown off with a normal pain of the joint line. As Dan had mentioned, Thessaly is one of our special tests. It was very popular for a period of time. Still pretty popular. I think it's a decent test, depending on the mechanism of injury. But the patient will stand on one leg with about 20 degrees of knee flexion, and then they'll rotate medially and rotate laterally. So I guess we're thinking here, if the mechanism, like I had described with my knee when I was running, I had a slightly bent knee, pivoted off my right knee, turn the other way, and had a meniscus tear. So that mechanism is exactly like this test. So I'm sure at the time of the injury, that would have bothered my knee to do. A positive test, like our other ones, is a sense of discomfort, a locking or catching over the knee that's reproducing their familiar pain. For the medial meniscus, it has a sensitivity of 83% and a specificity of 76%. For the lateral meniscus, it has a sensitivity of 68% and a specificity of 97%. So another test with a really high specificity for the lateral meniscus. So, you know, pretty good test there if you're considering a lateral meniscus tear, for sure.
Yeah. One of the things that I've talked to Lenny about here too, as well, because I remember sharing that little story about how Thessaly's had a great sensitivity specificity with one study and terrible for a secondary one. It's just that it's a tough movement in general. You're just balancing on one leg and rotating side to side. And there's a chance you just pick up other pathology with it. So false positives, right? I think the one thing about Thessaly is you got to make sure you don't bend the knee too much, because one of the ideas was that if you bend beyond around 10 to 20 degrees, your patella is going to engage the trochlear groove. So if you go too deep in your squat and you start rotating, now all of a sudden you're assessing the patellofemoral joint too. And we know that that's going to be the most common form of knee pain for most athletes or most individuals, really. So just make sure you're keeping it shallow, and just keep in mind, if someone has a really aggravated knee, this is likely to hurt with a variety of other pathologies as well. So I'm just here to rain on your parade, Kevin.
Rain on it, man.
Yeah, I
That's
like it
good, because
I don't know.
yeah, I think going through all these individually is important, so people know what tests are at their disposal. But I think, you know, not to jump ahead, but when we do get to the clinical practice guidelines, had a really good cluster of tests. And I think that's what's going to be the best for folks to use, is that cluster, because anyone in isolation, none of these sensitivities or specificities are amazing. But when you do have a certain number of these tests that are positive, it is a lot better. So keep raining, man.
Rain on.
Oh, here we go. Okay, so this is talking about the uh, what the clinical practice guidelines call the meniscal pathology composite score. So, if we do get someone coming in with a history of catching or locking, they have pain with forced hyperextension of the knee, pain with maximum passive knee flexion, joint line tenderness, and a pain reproduction of pain or an audible click with McMurray's maneuver. When we see all five of those positive, we start to think that there's a meniscal pathology. So if you want to pop to the next slide, there it is. Boom. Dan with all his good pictures below. So if we see here that there are greater than 5 positive findings of those 5 things, the specificity is as high as 99%. So they're testing positive with all 5 of these things. We are feeling pretty confident that they have a meniscus pathology. The sensitivity is not great. So just keep that in mind. Still not the best at ruling out, but a lot better at ruling in. Now, if we have greater than 3 positive findings, then our specificity drops a little bit from 99% to 90%, but we're still feeling pretty confident that this could be meniscus pathology. Now, conversely, if you only have greater than 1 positive finding, specificity is not great. Sensitivity is not too great there either. So I think to summarize these 5 is that when more and more of them are positive, we're getting more confident they could have meniscus pathology. But we still don't have a great way of ruling out meniscus pathology.
Yeah.
So keep that in mind.
Yeah, just one thing I'll say too is that when you have a negative test, that's when you're trying to rule things out. And sensitivity is for ruling things out. So if you had a whole bunch of negative tests, it's going to be more and more sensitive, right? So I think that those numbers just, that's saying that you have more positive tests. So I think that in a lot of ways, like that's not always valid, right? If you have a whole bunch of negative tests, then the sensitivity is probably going to go up, 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 up. They just didn't report on that data, right?
Gotcha.
So,
Yep.
yeah, I do think you can still kind of get some good. This is going back and forth. And even when I looked at this 2018 paper a couple of years ago for the first time, I was a little bit surprised. But usually, the sensitive tests I like to use are joint line tenderness and then just pain with end range flexion and extension. And if both of those are negative, I'm already starting to think this doesn't really seem like a meniscus injury, right? Although keep in mind, these studies are all over the place. Some of them show better sensitivities than others. So
Sweet. And then just to quickly go over what's the gold standard here. So if you are thinking that someone has a meniscus tear, you want to refer them to a doc that's going to get them an MRI. MRI is the gold standard, has fairly high specificity and sensitivity. So for the medial meniscus, sensitivity is 92%, specificity is 90%. Those are pretty solid numbers. For the lateral meniscus, sensitivity is 80% and specificity is 95%.
yeah,
And you will hear, I've had patients recently who on MRI, their meniscus looks okay, but they're going in for an ACL reconstruction. And when the doc gets in there, maybe the MRI didn't pick up on the tear, and they come out of surgery and they found out they had either a partial meniscectomy or a meniscus repair. So just, keep in mind, this isn't always 100% accurate. It's important to remember that. And the converse can be true too. Sometimes it looks a little bit worse on MRI, and then the doc goes in and it doesn't look too bad at all, and they think it's in an area that can heal, and they don't do anything to it, or so MRI is not perfect, and sometimes when they go in for surgery, that's when they really see what the meniscus looks like. But I think it's the best we have right now.
yeah, I was going to say too. They're getting these numbers, these sensitivity and specificity numbers from arthroscopy. So just like Kevin said, MRI is kind of one of the best tools we have. But really, at the end of the day, once the surgeon goes in, they're going to actually see what's going on within the joint. And sometimes it's a little surprising for patients. Not too often, just because MRI is a good test, but it does happen for sure.
Mhm.
All right, so now you have some good knowledge about clinical examination for meniscus tears. Now you need to know more of the background on meniscus tears. Well, I've got a video for you, and it lives right over top of Kevin's head here. We go over everything that physical therapists need to know about meniscus tears. Go ahead and click on that, and I'll see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So, Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.